So coming to the next chapter, cystic fibrosis. If you're going for any NEET exam, specifically the PGI pattern, cystic fibrosis, one question is definite. Okay. Theory also, it has been so many times asked, the short note on cystic fibrosis, we should know. Practical, usually it doesn't come. Clinical practice, yeah, in a way, important to suspect. Most of the diagnoses are done by pediatricians, so we do not get that patient very commonly to see, but when they transit to adult care, we should be at least knowing what cystic fibrosis means and what are the available therapeutic options there. Okay. So again, I will recommend, there is one link given here from NEJM. If your college has full access, go through this article, which is beautiful review article on cystic fibrosis and NEJM. So it has information more than what is given in Harrison, but I'm not very sure how important it is for you at this point, specifically or final year, to go in the detail of a rare topic or just to be happy with Harrison details. Okay. But if someone has interest and want to read cystic fibrosis, I will recommend this article to read. So this is from the same article image what we have taken, that it is the problem with the what we say epithelial transport channel. Okay, so this is one of the example of sweat duct and the epithelium. If we see, this is the area of detail. In normal sweat duct, the chloride from the duct to interstitium, the transfer is this through the CFTR channel. And in cystic fibrosis, those channels are disturbed, so the transfer is not smooth. Okay, that is a very simple thing to understand, that chloride channel transport with CFTR is impaired in case of cystic fibrosis. Okay, so what are the clinical manifestations which come? So we know that from very starting of MBBS, we have learned that cystic fibrosis is predominantly a respiratory disease. Along with that, it can have extra respiratory manifestation also. So first, what we will see, what is the respiratory manifestation? In respiratory, it causes the airway damage, in a way a bronchiectasis. It's a bronchiectatic presentation. What we have learned in previous chapter is one of the problem with cystic fibrosis. So copious, hyperviscous and adherent pulmonary secretion, which can obstruct small and medium sized airway. Okay, leading to bronchiectasis further, or the obstructive lung pathology. They can have a colonization with organisms like Staphylococcus, Haemophilus influenza, and Pseudomonas aeruginosa. This is very commonly asked in your MCQ. What are the organisms likely to be colonized in a mucosa or the airway of a cystic fibrosis? So these are the three, because there can be many, but these three are main which are commonly asked in Viva. So this Pseudomonas aeruginosa particularly, over a period of years, will adopt a mucoid phenotype, which confers the selective advantage for the pathogen and poor prognosis for the host. So whenever there is a mucoid phenotype, the penetration of antibiotic is very low. Due to that, it lasts there for a longer time, and the patient disease progress, and patient has poor prognosis. Okay, so respiratory manifestation of bronchiectasis, cystic fibrosis is simply like a bronchiectasis, and it can have predominantly the obstructive symptom and the repeated infection. Coming to the extrapulmonary manifestation, pancreatic is the second most common manifestation. And what happens there is a profound tissue destruction of the exocrine pancreas. So there will be the fibrotic scarring or the fatty replacement. There will be the cyst proliferation, loss of acinar tissue, and ablation of the normal pancreatic architecture. So ultimately, all this problem with pancreas will result in exocrine pancreatic insufficiency, where there will be the chronic malabsorption, poor growth, and fat-soluble vitamin insufficiency. So this will be the feature presentation from a pediatric child who has malabsorption along with failure to thrive or poor growth and fat-soluble vitamin insufficiency. Even in adult, there can be diabetes mellitus related to pancreatic problem, which is seen in around 30% of patients of cystic fibrosis. Not that common, but 30% is quite common and a very important factor. Because this pancreas is not working, the trypsinogen won't get converted to trypsin, and so there will be the high level of the immune reactive trypsinogen. That is the key screening test used for newborn. So this is again commonly asked in MCQ and Viva. What is the newborn screening test? So it's a serum immune reactive trypsinogen level, which are high, which can be used as a newborn screening test. Okay, so this is the pancreatic. The manifestations are very simple. When you have seen one or two patients of chronic pancreatitis, you can correlate very easily. They are chronic malabsorption, poor growth, fat soluble vitamin insufficiency, and some patients even diabetes. But in clinic, it happens sometimes opposite. They do not come with everything. Sometimes young diabetes comes, and if you think it is a malnourished, why not to think about something called cystic fibrosis? Okay, so don't make always rule when you are specifically practicing that all cystic fibrosis are supposed to have bronchiectasis. Okay, this might be the earliest or the first presentation, but if only when you have very high suspicion, or what you say that you have broad differential diagnosis, or what we discussed in last lecture, something which is not explainable. Okay, why this patient who is 16-year-old got diabetes? Okay, don't tell it's a type 1 diabetes from a day one. There's a malabsorption features and other things which you can really prove something. You are going to make a proper diagnosis which will have a different line of therapy. Okay, so on day one your therapy will be always good, but how you make diagnosis decides your long-term therapy and patient prognosis. Now this pancreatic problem, or the pancreatic problem of cystic fibrosis, are very common with this few mutation. One is F508 deletion, second is D551D, and the truncation allele. Okay, so this is something important to remember when it comes to MCQ. In clinical practice, I will never ever try to remember this, but in at least MCQ practice, you should be knowing. Liver problem, it can cause obstruction of the intrahepatic bile duct and parenchymal fibrosis, and there can be the multilobular cirrhosis in 4 to 15% of patients. So early age cirrhosis, one of the causes cystic fibrosis. In intestine also, whenever there is epithelium, cystic fibrosis is going to affect. That's a common thing to remember. So intestine, the content of intestinal lumen are often difficult to excrete, leading to meconium ileus, which can be a presentation in 10 to 20% of the newborn with cystic fibrosis, and distal intestinal obstruction syndrome in older individuals. So whenever there is a case of intestinal obstruction, again, it is wise to think that whether I am dealing with cystic fibrosis or not. In reproduction, there will be complete involution of the vas deferens and infertility despite functioning spermatogenesis. The problem primarily is at the epithelial level of vas deferens in cystic fibrosis, which leads to infertility. Around 99% of the male with cystic fibrosis are infertile. Okay, increased incidence of infertility in women also is seen with this, but in male it is 99% are infertile because of the problem at vas deferens, not at the spermatogenesis. So it is very important fact to remember that in extrapulmonary manifestation there can be involvement of pancreas, liver, intestine, and reproductive system. Now this is something what we see the question in the last NEET, that the difference of functional CFTR, like classical cystic fibrosis, where there is a no functional CFTR protein, which what we say the conventional or the classic cystic fibrosis, versus the functional CFTR protein when it is present, or non-classic cystic fibrosis, where there is the other genes involvement, that kind of cystic fibrosis. So this is the classic, this is non-classic. So as such, they are same, like both have chronic sinusitis. This is severe chronic bacterial infection of airway, while here it is chronic bacterial infection airway, which is later onset but variable. So again, this is a very important point. This patient may come with the feature of cystic fibrosis, but he may not have bronchiectasis from the starting or the recurrent infection. Third, very important point which was asked in MCQ, the pancreatic exocrine insufficiency is very common in classical phenotype, while here adequate pancreatic exocrine function is seen. So this is the one difference you must remember. Third is severe hepatobiliary disease is seen. Here it is not that common in the non-classic. Meconium ileus can be seen in at the 15 to 20% what we described already. Here again, not very common. So what we say is the below diaphragm, it's a hepatobiliary, pancreatic, or ilean involvement is common with your classical, not common with your atypical presentation or non-CFTR presentation. Sweat chloride volume, here it will be very high, 90 to 110, and sometimes 60 to 90. Normal is less than 40. where it's always high, but here it may be normal also, or sometime in the range of 60 to 90. Both have obstructive azoospermia. So the common thing is obstructive azoospermia and chronic sinusitis. Otherwise, there is a definite difference about all the things what we discussed. But this was the point which was asked in your NEET assess, which is not given in Harrison. So I just kept as a separate image. Again, this image you can find in the article in NEJM. So people sometimes go beyond Harrison, and this kind of things of common disease we should be knowing from a proper review article. Okay, so this is something very important to know for your MCQ part. Then comes the molecular genetics, and we have used this for MCQ in n number of times. Each thing from this image and information is important. That it is autosomal recessive in inheritance, and it's mostly the chromosome 7 which is involved, where the CFTR gene is there. And the CFTR mutation will disrupt the protein maturation, what we tell class 2 defect, which is the most common genetic abnormality. So in clinical practice or viva, you should know at this CFTR mutation, which is class 2 defect. Again, what we discussed initially, that's the G551D, which was common with pancreatic problem. It's a glycine to aspartic acid replacement at the CFTR position 551. Okay, G2D mutation or the replacement. And there will be inability to transport chloride or bicarb in the presence of ATP. That's a class 3 abnormality. So here, if you see, they have divided this abnormality in 5 classes depending on the function of cell. So the first class, if you see, which is this is the DNA where the CFTR gene will be located, and out of this DNA you are going to make RNA. That RNA is going to go here and make the protein at endoplasmic reticulum level, and this protein what will come out is supposed to get converted in a proper design and should go transport to the endoplasmic reticulum, which is smooth, right? And through that smooth endoplasmic reticulum, it goes to Golgi complex and it is out as a channel, the CFTR. That's how total process takes place. Sometimes it happens that it might be degraded if it is not formed properly, and the degradation function of protein is taken care by proteasome, right? So this is one of the problem which can be there. So if you see the class of defect, in class 1, there is a defect in the gene included the absence of synthesis. The synthesis step itself is not being taken care. So it's a class 1 defect, class 1 defect. Second is what we discussed, which is the most common, that is the maturation defect. So defective protein maturation and premature degradation. That's a class 2 defect. Because protein is not proper, the handling mechanism by proteasome will degrade it. So you never ever get the CFTR here because it got degraded here. That's the most common problem with cystic fibrosis what we get. Third is the disorder getting or regulation such as diminished ATP binding and hydrolysis, which is your class 3 defect. And then comes the further class 4 and 5 and 6 defects. Okay, so these are the 6 genetic defects or the classification of genetic defect or the functional problem which can lead to cystic fibrosis. In that class 2 is the most common problem. In class 3, the classical problem is pancreatic involvement. Okay, so this is very important for your MCQ. And if you know this image, you can just put out the normal function, how the protein is getting matured and channel comes up, and put 1, 2, 3, 4, you get the exact causes where the problem is. Okay, so in your short note also, you can have this kind of image which gives the insight to examiner that you understand what you're supposed to write. Okay, so in diagnostic workup, we always like it because it is not easily available. So the cardinal diagnostic test is CFTR mutation analysis and sweat electrolyte measurement. And we always keep looking for labs which can do sweat electrolyte test for us. So it's the following pilocyprin iontophoresis you have to do, and I will suggest best again go to YouTube and go for this, or I will send a link for a proper video how they actually do this, because it is something important. If we know, we can actually order further in a suspected patient. Okay, best thing is ask your pediatric colleague where they get it done, and then you can order it. Level of chloride markedly elevated in CF compared to the non-cystic fibrosis, and is highly specific. So if it is positive, it tells patient has cystic fibrosis. Then can be in vivo measurement of ion transport across the nasal airway. So these are the tests which is very important when you have CFTR mutation negative analysis or where your sweat electrode test measurement is normal. Now again, remember, like I will just tell, I love the chapter 3 of Harrison because it tells when taste is very specific, the sensitivity goes down. So it is likely that we may miss the patient of cystic fibrosis by this wet electrolyte test. And CFTR mutation is very simple. That if it's due to CFTR mutation, it is proven. But if it's due to other mutation, you may miss the diagnosis. So if these both are negative, but your clinical suspicion is still very high, you are supposed to go for the in vivo measurement of the ion transport across the nasal airway. So there will be the high transepithelial charge separation across the airway epithelial tissue and persistent failure of isoproterenol dependent chloride secretion via CFTR. Even in the rectal mucosal biopsy, you can get the CFTR activity checked. And here the majority people who are going to help you for this in vivo measurement of ion transport and of the nasal airway are ENT people. So if you're someone expert ENT clinician, you can actually get this test done through them. Management, it is like what we know already of bronchiectasis, we can extrapolate, but along with that, it is not just respiratory problem, it's a systemic disease, so many parts are involved. So standard of care, what is suggested by Harrison, if you see, exogenous pancreatic enzyme, nutritional supplementation, anti-inflammatory medication, bronchodilator, chronic or periodic oral or aerosolized antibiotic, what we saw already, 5 regimens. Recommended DNase aerosols, which is approved for cystic fibrosis related bronchiectasis, nebulized hypertonic saline, and chest physiotherapy. So these are the components should be there in part of your management of a patient with cystic fibrosis. Now, lung transplant, like whether this patient should undergo lung transplant or no. So threshold for deciding is when FEV1 measurement is less than 30 of predicted, or when there is a high hospitalization frequency or need for supplemental oxygen, the lung transplant can be one of the proper options. And when there is end stage cystic fibrosis pulmonary failure, it has 5 year survival rate of around 60% and median survival of more than 8 years, which makes it definitely a possible option to extend the life of patient with cystic fibrosis. But as we know that our practice as such doesn't tell us, or we do not have center easily available where we can think of referring a patient to lung transplant. But as such, it should be a proper clinical practice that if we have this problem which is very severe, patient should be offered at least the option, because you are going to have a possibility of median survival of extension of up to 8 years, which is quite high for the patient. So if family can actually afford it, it is feasible and possible. Now, this is something a new therapy, obviously not available in India, but there is something drug called ivacaftor and lumacaftor. These both are very repeatedly asked in MCQ. And what they does is they actually open the CFTR channel, which is affected in the case of cystic fibrosis. So it potentiates the CFTR channel opening and stimulate iron transport. It overcomes this G551D CFTR gating defect. So that is the importance of doing the proper genetic analysis. What is the exact problem? If this is the problem, ivacaftor can be your drug of choice, which can save the patient from the further damage in the lung transplant. Lumacaftor is already approved as a FDA approved corrector molecule. Again, this is the same mutation which it can partially overcome the defect of the CFTR biogenesis. So it is very important to remember this kind of things are available. And when you actually are practicing in some setup where patient can arrange things, if you offer them, you might be giving this drug in few years. Okay. So this is the case what is given in cystic fibrosis. Very importantly, that simple one pathophysiology kind of image you can explain in your answer when you are starting, followed by a clinical feature which you can divide in respiratory and non-respiratory. In non-respiratory, it is a pancreatic, liver, intestine, and reproductive. Along with that, if you want to mention this, you can mention, or at least you can keep it for your MCQ. Followed by that molecular genetic defect, what are the diagnostic workup you are supposed to do, and what is your management plan, and the new drugs, what we say for the ivacaftor and lumacaftor. So this is what finishes our short note on cystic fibrosis. Okay.